Welcome to Medicine A to Z. If you're new here, don't forget to hit that like button. Today we're diving into a crucial topic, essential diabetes checkups. Stay tuned. Diabetes-related complications. Patients with diabetes require ongoing evaluation for diabetes-related complications such as diabetic retinopathy, diabetic neuropathy, macrovascular diseases, and many more. Routine screenings, height, weight, and BMI. Every visit, smoking cessation. Counseling every visit, blood pressure every visit, dental examination annually, basic metabolic profile, annually HbA1c, every 3 to 6 months, vitamin B12 annually, vision loss and diabetes common. Issues, refractive errors, correctable, cataracts, glaucoma, retinopathy. 20% of patients without or with mild, moderate NPDR have visual impairment. 48% with severe NPDR or proliferative retinopathy have visual impairment. Diabetic retinopathy. The incidence increases over time in diabetic patients. Routine eye examination recommendations depend on type of diabetes, specific eye findings, risk factors like HbA1c levels. To reduce risk, maintain good glycemic control. Keep blood pressure under control. Frequency for retinopathy screening. Type 1 diabetes. First exam within 5 years after diagnosis. Yearly if retinopathy is present every 2 years, if no retinopathy, type 2 diabetes. At diagnosis yearly if retinopathy is present, every 2 years if no retinopathy. Pregnancy and pre-existing diabetes, prior to conception. During the first trimester, close follow-up throughout pregnancy and 1 year postpartum. Routine foot examination. Visual inspection at each visit, check for nail care issues. Look for poorly fitting footwear causing barotrauma. Identify fungal infections. Detect callus formation. Annual comprehensive foot examination. Identify risk factors for ulcers and amputation. Inspection of the feet. Assessment of pedal pulses. Testing for loss of protective sensation. Comprehensive foot examination. Quick overview. 1. Dermatologic. Check skin status. Observe color, thickness, dryness, and cracking. Sweating. Note any unusual sweating. Infection. Examine between toes for fungal infections. Ulceration. Look for sores or ulcers. Calluses. Blistering. Check for calluses, blistering, and any bleeding into calluses. 2. Musculoskeletal assessment. Deformities. Identify issues like claw toes or prominent metatarsal heads. Muscle wasting. Look for any wasting between the metatarsals. 3. Neurologic testing. Monofilament test. Use a 10G monofilament and one additional test, like vibration. Test with a 128 Hz tuning fork. Pinprick. Sensation. Check for sensation. Ankle reflexes. Assess reflexes. Vibration perception threshold VPT. 4. Vascular check. Foot pulses. Palpate pulses in the feet. ABI. Perform an ankle brachial index if needed. Monitoring urinary albumin excretion. Key points. Frequency test annually for all diabetes patients. Purpose to detect early signs of diabetic nephropathy. Timing. Type 1. Diabetes, start 5 years after diagnosis. Type 2. Diabetes, start at diagnosis. Confirming abnormal results. Repeat the test 3 times over 3. 6 months due to potential false positives. Note, factors like fever, exercise, heart failure, or acute hyperglycemia can cause temporary increases in albumin levels. Test interpretation. Normal rate, albumin excretion less than 30 milligrams per day. Moderately increased albuminuria, 30 to 300 milligrams per day. Indicative of diabetic nephropathy, unless another kidney disease is present. Severely increased albuminuria, more than 300 milligrams per day. Represents proteinuria and clinical kidney disease. Effective therapies. ACE inhibitors, ARBs, mineralocorticoid receptor antagonists, SGLT2 inhibitors, screening for coronary heart disease and heart failure. At every visit, measure blood pressure. Ask about cardiorespiratory symptoms. Address cardiovascular risk factors, smoking, weight, diet, and activity level. Initial and follow-up tests. Measure fasting, lipid profile during initial evaluation. Repeat follow-up measurements as necessary. Heart failure, screening ADA recommendation. Consider screening due to increased risk of heart disease and diabetes. Asymptomatic patients. Routine screening is not recommended. When to measure natriuretic peptides. Test BNP or NT-proBNP if patients show signs or symptoms of heart failure or have additional risk factors. Comorbidities to screen in diabetes patients' hearing. Impairment. Evaluate for hearing loss. Anemia. Common with chronic kidney disease. Type 1 diabetes. Watch for autoimmune gastritis and pernicious anemia. Metformin use can lead to vitamin B12 deficiency and anemia. Perform CBC at initial evaluation and annually. Periodontal disease. Annual dental exam is recommended for all diabetic patients, even those without teeth. Cognitive decline and related conditions, depression and anxiety, eating disorders. Fractures peripheral artery disease, PAD. For those 50 years old with diabetes, 10 years, microvascular disease, or foot complications. Perform ankle brachial index, ABI testing. Smoking lowers the threshold for ABI testing. Check peripheral pulses annually and evaluate further if diminished. Type 1 diabetes autoimmune disease screening. Higher risk. Type 1 diabetes patients are at increased risk for other autoimmune diseases. Common conditions: autoimmune thyroid disease, adrenal insufficiency, pernicious anemia, celiac disease. Screening autoimmune thyroid disease should be screened at diagnosis and periodically thereafter. Monitoring. Regularly check for symptoms of other autoimmune disorders. In type 2 diabetes, comorbidities to screen for include sleep apnea, metabolic dysfunction-associated steatotic liver disease, non-alcoholic fatty liver disease, and steatohepatitis. Certain cancers, particularly liver, pancreas, endometrium, colon, rectum, breast, bladder.
Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.